Good morning, everybody. Welcome back. It is September 15th. Cloudy outside and cool. Not your typical day, but it'll warm up. Here back with Gary, who's been on extended leave, and a lot's happened since he was gone. So today's going to be all COVID. So we're all in on COVID. So Gary, let's start off what we usually do. Let's look at the epidemiology, what's happening, because I think we're seeing some strong trends.
Yeah, so nationwide, most of what's circulating is the Delta variant, and nationwide, we can see the cases going down. There are still some hot spots in the US, but locally, and I'll show the first slide, this is a Sutter footprint, and you can see where the arrow is at the far right that we've had this Delta surge. The Delta surge actually went higher than the first surge we had, if you look at the graph. And then the second surge obviously was the one that happened last Christmas. But the Delta surge is consistently coming down. So we're coming down from that. I'll show you the next slide. The next slide shows our local hospitals, Sutter Santa Rosa Regional Hospital's data. And it shows that our positive testing rate is at 5.1%. It's also going down. This is a good number because this shows you people who are coming in for symptomatic cases. This isn't people who are getting tested to go back to school, getting tested to travel, or asymptomatic. So this testing rate represents predominantly people who are symptomatic. So in symptomatic cases, only 5% are testing positive. And that's gone down week after week, which is really good information. So I think we're on the backside of the Delta surge, but we're certainly not out of the woods yet. We still have moderate amount of activity.
Yeah, but you know what's encouraging is we were all unclear what's going to happen when schools got in, and parts of the nation I think that's problematic, but locally, and I think in the state of California, we've been in classes for a month, and we're still seeing these trends dropping. So that's
there are pockets of pediatric cases, not only in the world, but also in our country. I don't know why we're not seeing those locally. It might be that we have enough herd immunity in adults that it actually protects children. But you're right, we haven't seen a bump in pediatric cases locally. And that's a really good thing. I'm not a pediatric ID doc, and it's hard to see someone under 50, someone who's 20, someone who's 30, struggling on a ventilator. I just don't want to see that in a pediatric case.
Yeah. Anything new with the variants? I mean, Delta's everywhere, but is there anything coming along that might supplant that? Or
so 99% of what's circulating in the US as well as in our county is a Delta variant. And clearly we know that the Delta variant is 4 times or more contagious than the original SARS strain that came out of China. It's twice as more contagious than the Alpha strain that was in the UK. And the Delta strain is a reason why India had such a hard time. We've coped with it better than India. But the Delta strain, we think, is maybe a little bit more virulent, but not a lot more virulent. It's just more contagious. Now, we're tracking other variants. The Lambda variant was being tracked about the time as Delta. And the Mu variant, which came out of Colombia, is being tracked because that's overwhelmed Colombia's case rate. But the thought is from virologists and epidemiologists is that the Delta variant at this time won't be taken over by the Mu or the Lambda variant. It's still too contagious and has too much what's called viral fitness, and that allows it to predominate. So I think when the Delta variant goes down, we don't know what's going to happen in the fall. I mean, with kids going back to school, kids going back to college, and then the holidays coming up, that's a perfect storm for respiratory viruses like influenza. What will happen with COVID-19, we just don't know.
Yeah. I love how we humanize the virus, kind of like how we humanize the stock market. You say it's too fit to give up. Yeah. Let's get some practical information for our providers. Is there anything new on the ambulatory treatment, what we do primarily in our foundation?
There's been a lot of work at the Sutter level with monoclonal antibody. And with the new variants, a lot of the monoclonal antibodies have fallen by the wayside. But Regeneron, which is 2 monoclonal antibodies, Regeneron, a dual monoclonal antibody, still is holding up against the Delta variant. Now, early on, Sutter made a decision that we were going to do that in the ED. And they put out some guidelines in the emergency room that you needed to be symptomatic in less than 5 days. You needed a BMI over 35 and over the age of 65. That was our initial criteria. Then they opened that up to other criteria. But our ED is so impacted. They're too small. They struggle with having all the staff they need. Our ED didn't open that up. So Santa Rosa's emergency department, and I'll show this on a slide right now, they are giving monoclonal antibody in people symptomatic less than 5 days and either over the age of 65 or a BMI over 35. That's their criteria. But we also know that there's some mortality benefit. There's a survival benefit in diabetic patients that are well controlled. And so if you're a diabetic patient in the outpatient setting, especially if they're unvaccinated, has good control, they have a better chance of survival. And if they get hospitalized, we really work on controlling their diabetes in the hospital too. So that's a really practical thing, that the better diabetics are controlled, the better the chance of surviving COVID. Other than that, on the ambulatory side, there's not much else that works. And so what I'd like to put out there is on the other right side of this slide is what doesn't work. And just to know that there's been some traction here with, for example, the California Medical Board in doing things that are either unproven or that are harmful. So we know the hydroxychloroquine, with or without azithromycin, just doesn't work. Ivermectin, now the FDA has put out a strong statement, as well as the World Health Organization, don't use it, it doesn't work in the doses you need. Fluvoxamine was used as a potential treatment, and that's being studied still. And so I would not prescribe that on the outpatient side. Mega doses of vitamins don't seem to work, and some of them that are fat soluble, vitamin A, E, D, and K, can be toxic. Yeah. And then probenecid is the newest thing on the block. So probenecid is being studied, but if patients see these studies and they ask you to prescribe probenecid, I think there's no data to support that yet. So in the box to the right, these are things that are being either studied or not proven. I wouldn't prescribe them. And for example, the California Medical Board is looking closely at cases where people are doing things that are either unproven or harmful, even with good intentions, but could put patients in harm's way. Yeah. So I would be careful about that.
You know, I think the unfortunate thing about these treatments that are so popular on social media is they're just such a big distraction from primary prevention that it's a whole distraction from talking about vaccinations. And as we talk to patients in the clinics, we get stuck in that rut sometimes.
Oh, I see a lot of staff messages from docs. What about this? What about that? I'm getting a lot of questions. Yeah. I think this is a perfect storm. Having a pandemic in the period of social media where there's so much misinformation, what a headache, you know. And then we have this, you know, patients can email their doctor. Those three things just create for such a headache for the physician. So that's why something simple like this, I'm hoping, will be really helpful to you in the primary care offices, because clearly I know that you're getting bombed with messages from patients, and a lot of them are desperate messages, you know.
Gary, let's talk about breakthrough cases, because again, as we talk to the vaccine hesitant patients, they often bring up, well, you know, the people getting the vaccine are still getting sick too. And if you think about it, if you're in, say, a state where 75% of people are vaccinated, even if they have a very low incidence of infections, that could be a big absolute number. And so in reality, if 75% of people are vaccinated, you know, the number of absolute vaccinated people with an infection could be comparable to the number of unvaccinated people. Right. And so that distorts the discussion. But is there anything new about breakthrough infections?
Yeah, so you're absolutely right, Gary. It's a complicated issue because there are a lot of conflicting things that confuse people. Yeah. Well, we have a more contagious variant. You know, we need a higher number to reach herd immunity. Mm-hmm. And really hot off the press is this new information from the UK. And the data I'm going to show you from the United Kingdom also reflects what's happening in the US, where breakthrough cases are very low. Let me show you this graph. This is from the UK, and this represents what they had with the Alpha and the Delta variant, the first part of 2021 from January to June. In the UK, they had 51,000 deaths. And on the graph to the right, most of those deaths are reflected with the blue line, and the blue line represents the unvaccinated mortality marker. For people who had completed 2 doses of a vaccine, whether that's an mRNA vaccine in the AstraZeneca in the UK, or 2 mRNA vaccines, and at least 3 weeks had gone by to build immunity, only 0.5% of the deaths in the UK represented those patients. So in the UK, 99.5% of the deaths were people who were unvaccinated or partially vaccinated. You know, so getting 1 dose is good, but 1 dose of a vaccine is probably like getting through natural infection. You don't build that much immunity. And so only 0.5% of the deaths were people who were vaccinated fully, and they represented for the majority of patients who are either over the age of 80 or are very frail for other medical reasons. So what I really like about this one is if you look at the very green line at the bottom, it looks like that's the horizontal line. Well, that's the line of hospital mortality. So with a more contagious variant and a vaccine that's 85 to 95% effective with the Delta variant, you will have some breakthrough infections. Mm-hmm. But most of those breakthrough infections are asymptomatic or super mild. Rarely do they get hospitalized. And even more rarely than that, do people not survive. The people who don't survive are very aged, and with a lot of comorbidities. And that's probably where we're going to go when we start talking about the booster, with the boosters for vaccination. So I'm really reassured by this slide from the UK. I'm sorry it's so busy, but I want to give you the information on the slide so you can really look at it, pause the video, look at the data, look at the slide, and I find this very reassuring.
So let's talk about boosters, because I just read that in the UK, at least they have publicized the decision to give a third dose, a booster, to a vast swath of their population.
Yeah, so the UK just came out with that about 2 days ago, saying that everyone over 50 is going to get a vaccine. And in the US, we think that boosters are a good idea, but there's not the same inkling. And actually, there were 2 people on the FDA advisory committee who left the FDA, and they were very vocal about boosters might not be needed. What we know is that the data that Anthony Fauci talks a lot about, that over 6 months, over 8 months, we see immunity wane. That's a serologic phenomenon. In the lab, we see that neutralizing antibody will drop over time after 2 shots of an mRNA vaccine. Now, does that laboratory data mean that you're going to be vulnerable to infection? We're not seeing that yet. We're not seeing people who are vaccinated come into the hospital, especially at our hospital, and then get hospitalized and be put on a ventilator. So, and the reason why is so even though your neutralizing antibody titers may fall off at 6 months, you still have lymphocytes, you have memory T cells and B cells that are waiting for the virus. So I think that over time, we're probably going to need a third booster, but we're going to need it strategically in those who are elderly, in those with comorbidities, and maybe a little bit more so for healthcare workers because we get exposed to the virus so much. But I don't think it's going to be the blanket statement for all of the UK. What's confusing to the public is we have serologic data in the test tube that shows a little bit of waning neutralizing antibodies, but we're not seeing clinical cases. So the UK is being a little bit more aggressive about boosters. The United States is being more conservative, and the World Health Organization is asking everyone to be conservative because they still need to vaccinate countries where there's no vaccine yet.
I think that is another confounding variable for our hesitant patients to say, or anybody actually, the understanding that they say we're losing our immunity, we need to get a booster. Well, no, we're losing numbers. An objective measurement doesn't necessarily correlate with immunity on a clinical side.
That's exactly right.
Yeah. Anything new in vaccines in general?
Well, a couple things. One, what about pediatric vaccines? I think it's absolutely essential we get kids vaccinated, especially now that they're going back to school. And the FDA is going to vote probably in the next week or 2 on pediatric vaccine. And we expect by hopefully mid-October, children 5 and up will be available for the Pfizer vaccine. That's the expectation of the CDC from the FDA. So that's great information because as kids go back to school in the fall, especially elementary and high school kids, we really want to be careful that then comes Halloween, then comes Thanksgiving, then comes Christmas, and all these people are mixing in the school systems and college kids traveling abroad, then they come back. And that's a perfect storm for any virus to kind of show its head. We don't want to repeat last year's season during the holidays of COVID-19 because that was really rough. The other thing new about the vaccines, which I think is really interesting, and I'll show you this slide, there's a joint statement. So this joint statement comes from the Federation of State Medical Boards, and this is a governing board. And the joint statement is that providing misinformation about the COVID vaccine contradicts physicians' ethical and professional responsibilities, and you may be subject to disciplinary actions. Now that's a very strong statement. And there's been some purposeful and intentional misinformation about vaccines that contradicts science. And this governing board has made a statement about that. Now the American Board of Family Medicine, the American Board of Internal Medicine, and the American Board of Pediatrics has stepped forward together and made a joint statement to support that. So I think that's really good. I think that we should really be evidence-based. For example, should we really tell patients not to wear seatbelts? We know it works, right? And I think that the safety of this vaccine and the efficacy of this vaccine really warrants truthful information. I think we should tell patients that everything we do in life is a risk and a benefit.
Right.
How big is a risk, or how small is a risk? How big is a benefit? And I think the benefit of the vaccines far outweighs the very rare side effects we're seeing.
Yeah.
And I think when you purposely don't promote that truthful information, I think you put patients in harm's way.
Yeah.
So anyway, I think this is new information, and For those of us that are board certified, I think that's really important to know that we're held to a higher standard.
Yeah. You know, as we go on, since the vaccines got released, we continue to get more and more data, which says the same thing,
Right.
that vaccinations are the treatment for COVID. So
Right.
keep pounding that message out there. I know it's tough because the patients we're often seeing in the office are not vaccinated. It's a tough discussion, so hang in there with that. So we're going to stop there for today. Again, if you guys have specific questions that you'd like addressed for the audience, please submit those to us. We're happy to answer those. So Gary, thanks for your help and welcome back.
Oh, thanks. It's good to be back.